So in our next session, we're going to return to the issue of healthcare. We all know by now that yesterday we had some very encouraging news about a potential vaccine from Pfizer. There may be more to come. We've got the AstraZeneca vaccine, which is in late stage trials. We've got multiple other vaccine projects which are coming down the track. So it's not impossible that we may, end up at the turn of the year with 3 or 4 viable vaccines. So it really does feel like we are turning a corner. But either way, I think it's fair to say that 2020 has been a year in which Britain's healthcare system has been transformed both by the trauma of dealing with coronavirus and by new technology. From online appointments to the use of patient and public health data in new ways to allocate resources, staff and medical equipment. Many of these changes, I think, are likely to endure long after the pandemic ends. But this also raises a lot of questions about privacy, about the commercialization of the NHS. I believe that Ernst & Young has valued the NHS data resource as being worth as much as £9 billion. And is this the kind of road that we want to go down? So in our next session, we're going to debate the role that tech companies have played in tackling the pandemic and the impact on the NHS, and also what positive contribution technology can play in building a better health service and coping with the next pandemic. So I'll hand back over to Harry to lead the discussion.
Thanks very much, Robin. It's going to be a fascinating session again. You've got more of me, so I apologise for that, but we're going to have guests who will distract you from me, and they're the real attention, and it's going to be a great session. As Robin says, it's a real divided year for health tech, because on the one hand, you've just got these breakthrough moments which make the front pages as never before, like today's front pages, and makes us all sigh with relief. And we've become familiar with men in white coats and researchers around the world as never before, telling us minute by minute what scientific breakthroughs are, and we're paying attention as never before. And it's clearly an extraordinary time to be in science and med tech, health tech. On the other hand, that does, as Robin says, raise a huge number of questions about access to data, because so much of health tech runs on crunching big amounts of data. Now, a lot of that can be anonymized, but still there's a huge reluctance, I think, on behalf of many patients to hand over their data, and they're worried that somehow big tech is going to get its hands on their data, make money out of it, and privacy laws or privacy boundaries are going to be crossed in a way which makes them feel very uncomfortable. But to address both the upsides and the downsides, all the potential pitfalls of health tech's bonanza and boom year, we've got a fantastic panel. First, I'm going to introduce, we've got Ali Parsa, who is the CEO of Babylon Health. Now, many of you will know Babylon Health because it is responsible for GP at Hand, this technology which allows you to get a teleconference with a general practitioner. It has AI chatbots, which allows you to diagnose with potentially conditions that you might have. So it really is at the cutting edge of health tech and what we expect from health tech, digitization of services which used to be physical, going to your GP surgery. So we've got Ali. We've also got Junaid Bajwa. He's the chief medical scientist at Microsoft Research. He's a practicing physician in the NHS. Sorry if my microphone's falling out. At the NHS. He was before the global lead for the strategic alliances and solutions at the Global Digital Centre of Excellence at Merck, where he led a range of strategic initiatives to improve patient care. And interestingly, he also founded Velocity Health as Europe's first prevention-focused digital health accelerator in partnership with Telefonica. And he led his team to deliver the NHS test bed in partnership with Verily Life Sciences, which is part of Alphabet, Google, as we know it. And I think so he really knows that integration between public and private when it comes to healthcare. And also I'm delighted to have Noor Shaka here. She's a serial biotech entrepreneur with a record of achievements in AI, and she has an assistant professorship from Aalborg University, and she's written many papers, and is an inventor with patents as well. And what she's really fascinated about is getting on a mission to cure cancer with the power of data and AI, to try and find those techniques which will allow us to make breakthroughs against that terrible disease using data, using artificial intelligence. She's an MIT innovator, Massachusetts Institute of Technology innovator under 35, one of the BBC's 100 women for 2019 and a rising star for 2020. So let me thank you all for joining us here. Junaid, I want to start with you. It's been a hugely dramatic year, as I was suggesting, and you're at Microsoft. Microsoft was brought in by the government to help with the NHS reacting to the pandemic. What is it like being part of a huge private company going into one of the UK's biggest, if not the biggest, public enterprise, public state sector organizations, and trying to gel those two things? How did you find it? What happened? Tell us the upsides and the downsides.
Thank you so much for the opportunity. So I suppose the answer to that question is actually, how do you navigate the NHS, and what lessons do you learn from navigating the NHS to then navigating different corporate organizations as well? So I spent most of my last 15 years across the payer, provider, regulatory, and life sciences side of healthcare. And I'd take every single job that I've done as a different rotation, be that a rotation through a hospital, a rotation through a CCG or a payer, a rotation through a pharma company, and now at Microsoft. And Microsoft's mission really to think about how we empower every single individual on the planet to achieve more with technology, I think sings very similarly to what the NHS Constitution talks about around how do you bring the best of science and the limits of science to healthcare and marry that with care and compassion. And so at the time of the pandemic, you almost had this wartime effort, which I think the other speakers previously have spoken about, where people needed to think about a resilience model around what can we do to try and sustain a level of care. The NHS has to remain open. What can we do to allow communication to take place? Beyond communication, how do we ensure that patients have safe levels of care? Around that, how are we managing this new disease? How are we sharing information across countries, across boundaries, and thinking about what we can do for research? And within a year since COVID-19 was identified, we've now got breakthroughs in vaccines, which have been powered by digital data and analytics. We've got almost a digital first national health service in many parts of the country, where patients and clinicians who historically have maybe pushed against thinking about the notion of telemedicine and teletechnology to try and empower their digital first experience are now embracing what that could look like and changing the models of care. And Microsoft within that is I joined about 4.5 months ago, and I've joined in lockdown. I've joined and just leveraged Teams to the best of my ability, and it's been a fantastic experience actually, and one that I think Microsoft has really stepped up to the plate to think about how it can be a partner to the NHS in a time of need.
But when you tell people, I mean, none of us are having parties or dinner parties anymore, but I mean, if you sit down next to someone theoretically on Zoom, let's say, and say, I work for Microsoft, we're helping the NHS, is the response big tech should not be part of the NHS, or thank goodness Microsoft is helping out because the NHS could never possibly grapple with all that data. We need someone to come in from outside.
A bit of both, if I'm honest. So my old medical school friends, I think, still are very curious, but also are suspicious. And I think the way that I would answer that question is one of what can the NHS do alone, but what can we do to think about scientific breakthroughs powered by technology? And what can all the tech players do in that space? And what are the differentiators for Microsoft as it relates to trust, privacy, and some of the research that we're doing? So I get the chance to, from a research mandate, my mandate is how do you begin to transform the practice of medicine with human-centered AI? And for that, it's a huge opportunity, but thinking about what is the practice of medicine? It's both an art and a science. How do we ensure that we keep humans in the loop, but allow them to have superpowers, augmenting what the superpowers that they have already to offer better care, give them time back to patients? And we're all very, very curious about the role technology can play in a world where technology is having an impact on all facets of our life. There is clearly people who are suspicious, but I think through dialogue, through having conversations, ensuring that we do things in the right way, leveraging previous experiences that you mentioned in the introduction, happy to go into some of those in detail. How do we ensure that whatever we do, we're doing the right thing, we're doing it in the right way?
So they've no reason to be suspicious, even if they do feel suspicious.
I don't. From everything that I've seen over the last few months, I think there's historic prejudice or misconceptions, which can be broken down through active dialogue.
Brilliant. Thanks so much. Now, Ali, I want to come on to you. You, of course, are absolutely at the cutting edge of delivering health tech. This is not about data giving us insights, but actually digital services giving face-to-face care with GP at hand, and of course with the chatbots that you do at Babylon. Just explain how the pandemic has affected your company and the stresses and strains that must have put on you.
We created Babylon around one single insight, that we spend most of our time in healthcare not dealing with healthcare, but dealing with sick care. We fundamentally wait for people to get ill, and then we deal with their illnesses, and we do heroic jobs in our sick care institutions, hospitals, GP surgeries, to bring them back to health. We spend very little time globally, and that is not just in Britain, all over the world, to doing with human body what we do with our cars. If you remember 20, 30 years ago, we would wait for our cars to break down, and then we would take them to a garage or a mechanic who fixes it. Today, we don't do that anymore. We have put so many sensors in our cars, and we take them for annual services, and we try to predict when things go wrong and fix it. We do it with our airplanes. We do it with all of our assets. We just don't seem to do that with our human body. And the insight we had in Babylon is that the right way of delivering healthcare is to invest a lot of time upfront to try and keep people healthy, rather than to wait for them to get sick and then fix that. And I think what the pandemic did was brought that insight to the whole world, and basically made the whole world to go from, no, we have to deal with sick care. Our job is to sit in our ivory towers and just wait for our patients to get ill and then come to us, to a place that says we have to keep the population healthy because we can't deal with the catastrophe of a very large number of people getting ill at the same time with this virus. And I think, and my hope is, more than anything else, that as we come out of this pandemic, and we will come out of this pandemic, but as we come out of this pandemic, we take away with us that lesson. Because the pandemic, the virus, the coronavirus, was not the only health crisis we were having. You and I were seeing in this country 8,000 to 10,000 people die every year because of suicide. People who have committed and lost their lives to suicide. Globally, we lose 1 million people a year to suicide. But we do very little about mental health, apart from reactive. We do it to diabetes. We do very little with dealing with that. So I hope that's the lesson we take away. But I think the pandemic, in a way, for us, demonstrated that is the right way of doing healthcare is to keep people healthy rather than wait for them to get sick. I don't know if that covers the question you asked.
No, it didn't at all, but it was a really fascinating answer. I'm going to come back and I'm going to come back to exactly what you said, but I'd just like to ask, did you see your systems come under strain or buckle during the pandemic? Did you find that lots more people were using you and calling you up?
Yes, well, we did, but the system didn't come under pressure, because we always kind of thought that, look, what we need to do is deal with people digitally as much as possible first. So what we found is, as soon as the pandemic started, people started, as you quite rightly say, calling our doctors and nurses, but the doctor behind a mobile phone is as rare as a doctor in real inside a real physical place. They are as busy. So what we had to do was to see what are the questions they're asking. Believe it or not, we had people asking our doctors, because they're immediately available, right? You press a button, you can talk to a doctor. So they were asking our doctors and nurses, how do I wash my hand? The government says, wash your hand. How do I do that? So we did a video that we put on within a few hours of it, almost, of getting those data in. And the video was saying, how do you wash your hand? And we pushed that out. And we had 100,000 people a day watching that video. And we saw those questions really going down. Then we put on anything that we couldn't answer digitally or through our chat, but we put on human beings, clinically supervised, but not clinicians, who could answer questions through chats with people. And that way, we managed to take almost 80% of the pressure away from our doctors and nurses, who could then focus on more ill sections of our population. So in New York, when Mount Sinai Hospital was besieged by patients at the peak of the epidemic, we partnered with Mount Sinai, put the same system in, and managed to do a great the relief there. But we actually, while a lot of telemedicine companies, and that's why telemedicine, putting a doctor behind a mobile phone on its own just doesn't work. You have to look at every piece of the need of a population and say, how do I most efficiently and effectively deal with it? Some of it can be done by information, some of it can be done by AI, some of it can be done by chat, and some of it, of course, needs nurses and doctors to deal with it. But it's a combination of all of that. But as I said, we quadrupled the number of patients and visits we had without almost adding any clinical resource. And that was a great, if you wish, confirmation that the model works.
Fantastic. Now, that is a great understanding of what you can do when you begin to see data. And, I want to understand, you talked about sensors in our cars, and, it brings to mind whether we should have sensors in ourselves to understand what's going on inside us all the time, to have better real-time monitoring. I want to come to Noor now. Now, Noor, you're looking at data to try and improve therapeutics treatments for cancers. Does the data come to you? Is data always a good thing in medicine? Does it come to you in the right ways? Is it in the right formats? Is it always useful? And how do you deal with patient concern that what Ali is talking about sort of more and more information being produced by our bodies in the way that, just like more and more information is produced by our cars or aeroplanes, that can presumably be overwhelming. So how do you deal with it? And is it ethically the right thing to do?
True. Yeah. That's actually a very interesting discussion, very interesting question as well. In terms of AI and machine learning using data, it's rarely the case that the data is just ready when you get it. You have to do a lot of cleaning, a lot of curation, and it really depends on the task that you're solving, the way you look at the data and what you need to do with it before it's machine learning ready. So we have a lot of machine learning tools as well to help us kind of clean that data and get the information and knowledge out of it. So data in its pure form is really not much. It's just sometimes noise, and you need to get that kind of information out of it. And we do a lot of that. In terms of like plugging properly ourselves in sensors, I think a lot of people at the moment are using, for example, Apple Watch to kind of monitor our health, the calories that we spend every day, our healthy habits, and so on and so forth. There is a lot of information coming into digital platforms, and I think we have probably in the past 4 years have witnessed increasing awareness, both by people who have access.
No, I'm just going to cut you off there. Sorry, I'm just going to interrupt. No, sorry, because we're just having some feedback on your microphone. So I'm just going to cut away from you there, just while we sort it out. I don't know, and then we'll come back to you in a minute once it's sorted out, because I thought that was just me, but apparently it's a bit wider than that. So we'll sort that out. I'll come back to you to hear that question. And I just want to go on now to Junaid. Robin was talking about in the intro about the value of the NHS's own data, and it being worth billions, multi-billions. I talk to Ara Darzai sometimes, who's a very distinguished doctor I'm sure you all know, and Ara is passionate about the NHS capitalizing on its own data to fund itself and to reassure people out there that they should give up suitably anonymized data to the NHS to help treatments be improved. What do you think about that, Junaid? Could the NHS, which is so well regarded around the world, including from America, for its data, because it's not fragmented across many providers, but is this monolithic thing, could data become not just a therapeutic resource for the NHS in future, but a financial resource as well?
No, it's a great question. And maybe building on something which I think Noor was talking about earlier, which was data in my mind isn't enough. You need to demonstrate insights, and insights aren't enough. You need to demonstrate outcomes, especially in the National Health Service and especially in a general healthcare service. So data in my mind is like saying, hey, we've got the alphabet. Isn't the alphabet a great thing? But actually the alphabet isn't the book, isn't the story, isn't the sentence, isn't the narrative that you create. And once you read it, it's not the emotion that you get that says, I want more. Data by itself isn't necessarily the refined product that is the same product that you put into a car or a plane that allows it to be fuel, nor is it that plastic. And you have to think about the infrastructure that you need to build, be that the curation that Noor was talking about, or indeed the solutions that Ali was talking about, ultimately to create utility out of that data. So I think the Ernst & Young report that came out early this year, late last year, around the total value, I think it's got people talking. And there are certainly groups around the NHS who are now thinking about how do you put a value on that. But it raises lots of questions, like you say. So what is the consultation and the conversation that we've had with the public to make sure that they understand what their data is being used for today, what it could be used for tomorrow? Where does that data sit? The fact that the data sits in multiple different healthcare electronic records, even within a general practice, and it sits within multiple different records within secondary care, and in addition to that sits in different records in your social care or local authority database. Your health isn't just your medical record. Your health is your behaviour data, your economic data, your social determinants data, all together. The total value of that for the purposes of improving health, improving prevention, improving quality of life is immense. But there's a journey that I think we're all having to go on. And I believe fundamentally that we need to have, as a healthcare service, a better conversation with the public so that we do this in a transparent manner and ensuring that they understand and we understand how our data is being used, be that for the purposes of therapeutic research or be that for the purposes of quality improvement and system improvement and service improvement within the National Health Service.
Ali, you deliver cutting-edge treatments, or the frontline treatments. GPs talking to patients. Obviously, people who use the service, like the health secretary himself, are sort of early adopters. What kind of battles are you facing to convince people who aren't early adopters that they too should talk digitally to doctors instead of going round to their GP surgery? I'm not sure how happy my 90-year-old father would be telling a doctor over a screen that he's never met before his ills and woes, whereas at his GP surgery he's known the doctor all their career. How do you convince people who aren't early adopters of the benefits of medicine at distance?
I think you use a really good example here of your father who has a clinicians that he trusts and has been with for a long time, and he has the time and the availability to go and see that clinicians. Well, why should your father change? It seems like that is exactly the right solution for that individual. And I think that people get overzealous about technology or one way of doing something versus the other. In the same way that is wrong to say that everybody has to see their doctor in their single-handed GP practice, and their doctor should be the person who gave birth to them or was there when it was born, and that doesn't exist for many. it is equally wrong to say everybody should see their doctors through the most advanced digital way with the aid of AI. And on the other front, you just don't want that zealot approach. You just, what we want to do, and I think what the system will benefit from, is to give everybody the choice and to create different options for different people to see at what time what suits them. In United Kingdom, the model for us is that we are allocated the GP, and unfortunately, in UK, for us to operate, people need to choose whether they have a physical GP or Babylon with its physical clinics, and so on and so forth. In other countries, in Canada and United States, we don't do that. We work hand in hand, side by side, with physical practices and hospitals and other clinics, whereby people will come to us when they need to, go see somebody physically when they need to, and keep all relationships according to their needs. I don't think this is an either or solution. I think in the same way that I do some of my shopping in Amazon, some of my shopping at Marks and Spencer, some of my shopping at local shop next door to me to support them, the same should happen with healthcare. As we mature, these contradictions and should go away, and instead we should have a system where everybody do their best.
Sure, but we've seen how Amazon has taken a huge share of commerce, and so once trends are established in tech, they get very quickly established in these cycles. I want to come on to Noor very quickly, but Ali, you've had at Babylon a data breach earlier this year, but I presume you will reassure customers and patients that they can trust your service with their data.
Absolutely right. And look, any single data breach is one too many. But just think about what happened there. It was one single patient having, for a very short period of time, in minutes, access to another patient's partial conversation. And that happened for a few minutes. We found it, we closed it. It didn't happen again. The problem got solved to a degree that the information commissioner commended the work the team did, and others said that something goes wrong, but for anybody at anything, what matters is how do you deal with it and how well prepared you are to fix it. And I think we did that. That happens in real life all the time. A doctor sends by mistake somebody's records to somewhere else. A hospital misplaces things. We had massive breaches in the NHS computers, if you remember, only a couple of years ago. We should be super careful not to just find something that goes wrong with one part of this ecosystem and try and make big news out of it. And our single data breach, and I don't defend, I think it was awful, and our team was mortified by it, but it was one single instance. But to still look at it, it kind of was news in 70 countries. It made it to the top of BBC News. It was in 360, 70 publications across the world. And when you compare that to all the other things that happen, you kind of see that there is a little bit of, when we on one hand, we exaggerate our successes, on the other hand, we exaggerate our failures. And I think that for healthcare, for digital healthcare, for technology in healthcare, to come and become comfortable as part of the whole system, we need to kind of see it for its realities of its good, its bad, its failures, its successes, and put it all in balance together. And people will trust it. So coming back to your question, people will trust it when we have the honesty to tell them exactly as it is, and to share with them exactly how it operates, and also how it operates in relation to the rest of the system. Because it's in this particular case, as you know, the rest of the system has its own challenges. It sometimes just doesn't make the news.
Of course, Ali, and I think that's the case, isn't it? So often with tech that it doesn't have to equal the status quo. It has to much improve on the status quo if you want people to not adopt new behaviours. They're comfortable with the system as it is, even with many failures. But if they want them to adopt new behaviours, you're going to have to give them a very convincing reason to adopt those new behaviours. It's going to have to be much better than before, much safer, the data is going to be much more protected. if we want people to move forward. Now, Noor, you're there. It's great to have you on a better line. Thank goodness. We were talking, Ali, as I said, was mentioning data. You were talking about sensors, the way we sense our cars, have sensors in our cars, our aeroplanes. You were talking, I think, I could hear in my earpiece, about the sensors we're all beginning to wear now more and more. Apple watches, these watches which can take your blood oxygen, they can give you a sort of permanent ECG, incredible real-time data we're getting on all of us now. Tell me a bit about what you're optimistic about this wealth of data coming through, and whether we can manage it, not just in terms of security, but also logistically. Are we going to need to have Excel sheets with more columns and rows on them to fit in all that data?
I think it's really a number of there are a number of reasons to discuss this discussion, and a number of really ways to look at it. I think on one hand, we need to get people to understand the benefit of really getting insights from their data and how that benefit their health. So that's one thing, because sometimes people get into the thinking of privacy and all of that and forget the benefit and the added value of actually tracking and notifying them when something is going wrong. But at the other end, we also need to understand that we need also to educate them and to educate ourselves around how do we deal with privacy issues, and how do we explain to people what's going to happen if something went wrong. And I think we are now coming to an age where actually AI, machine learning, and technology can help us get better at it. Over the past few years, just kind of within the past, I think for 5 years, we've seen a lot of talks around blockchain, around federated learning, and those are all technology that helps us get the insights without actually getting access to the data. And what I really mean by that is that your data can still stay, say, on your Apple Watch. It doesn't really have to go into the cloud. It doesn't have to go to Apple. On your mobile, it doesn't have to go anywhere. It can stay just there. And then you can build models and technologies that can just learn, and then the model can transfer into another place without getting the data with it. So that's a way to ensure that our data is ours. It's not really going into another organization. We still have control over what's been created by us, and we get to say what's going to be transformed, what's going to be staying with us. So that's actually a crucial point. And I think it's both on the people, the individuals, and it's also on the organizations to get those methods implemented on scale, so that people understand that we're working toward the better privacy regulations for all of us. And at the same time, we're reaping the benefit that helps us better understand the human health and provide better medicines, better diagnostics, and better healthcare in general.
Tell us what you're doing specifically and how you hope to challenge cancer with data.
So for us, we really work on the, I would say, early stages of drug discovery, which is, as you probably know, is a very, very long process. It takes about 15 years to put one drug in the market, and the failure rate is usually very actually upsetting. It's about 92% failures once you reach the clinical trials. So we work on the early stages of really designing those chemical structures that helps us get that process shorter, reducing the cost, and also designing the drugs or the potential candidate for a drug for the right patient at the right time. What that really means is that we require usually access to cell lines, so primary patient cell lines. Those are basically biopsies from patients, and also access to drug candidates or drugs, basically chemical structures, compounds that have been created or produced by other pharmaceutical companies. As you can imagine, accessing those from pharmaceutical companies or even other organizations can be quite a hurdle, just because they're really their crown jewel, and there is a lot of IP confidentiality issues around accessing those. So that's actually where those methods that I talked about come to play, because then when you tell them that you're not really accessing their data per se, the model is going to see the data, the model is going to train. So you're basically building a mathematical model on that data, and then the model comes back to us. We don't really see it anymore. That gets them to kind of think in think more positively about how we're using AI, how we're using machine learning, and be more kind of enthusiastic about it. And we've seen that model also applies to clinical data. So phase one, phase two clinical trials, where you get access to patient data on specific clinical trials. And again, the patient data doesn't really transform, it stays where it is, and the model learns from that data, and then it goes into another organization, learn from their data, and it moves on. And that's how it improves without actually preaching or getting people or organization worried about the use of their patient data.
Okay, fantastic. Thanks. Junaid, I want to come back to you. Noor there's talking about new technologies, whether blockchain technologies, other encryption technologies, which effectively allow statistical models, which effectively allow a statistical model to go in and assess the data, sort of test the water, as it were, and then learn from it, and then emerge back out without ever taking the data out of your phone, off your Apple Watch. And that sounds like a fantastic new way of beginning to reassure patients that their data is not being sucked off their device and into some big tech's vault somewhere. But also I wonder what other kinds of reassurance mechanisms there might be, because we talk so much about artificial intelligence, running on data, but artificial intelligence is basically a black box to most people. It's algorithms which people don't understand. There's very little transparency. They don't really know what's going on. Shouldn't we begin to apply the same level of medical ethics that we do, peer review, transparency, having blinded models and unblind, as we're seeing with the Pfizer vaccine this morning, towards the basis of artificial intelligence, towards algorithms, just as we do to drugs? What can we do on AI? What can we do on encryption to really instill patient confidence?
So there's a lot there in what you said, and I'd probably agree with all of it. So let's start about what is AI. AI means a lot of different things to a lot of different people, and it's almost become definitely a buzzword. But are we actually asking the right questions that require an AI response? And then for AI to fully have full utility and benefit, I think there are three things that need to exist. One is the data itself, and that could be large data sets or small data sets. You then need domain expertise to contextualize that data in order to train the models that Noor was referencing earlier. And you also then need massive compute power that allows you to do the analysis that you need to in the cloud. And all of that needs to be done in a secure manner, in a trusted manner. And companies that are offering these services, be they AI, need to be doing them in an equitable and responsible manner. So at Microsoft, we have a framework around responsible AI as we think through data across multiple different industries, and ensuring that both we're training colleagues leveraging the data, but doing things in the right way with our partners, providing our partners and empowering our partners to do the work that they wish to do, and building our technology that allows them to do the next breakthrough that they wish to, be that in pharma, in drug discovery, or through a different channel itself. But the notion of creating interoperable, safe, frictionless exchange of health information, almost containerizing it and allow the models to be transmitted so that they can be handled in a confidential manner. I absolutely think that technologies like this should create an added trust in the future, and companies engaging in this space should have frameworks and mechanisms and standards that they hold themselves to, and that industry holds itself to ensure that we are doing things in the right way.
Ali, very briefly, we're coming down to our last 5 minutes now. Ali, I want to ask you briefly, you talked about sensors. It fired off a picture in my mind of us all wearing sensors. Perhaps we already do externally, Apple Watches, our mobile phones, taking all this data. Do you see a world in which we'll have internal sensors as well? We talk nanotechnology, tiny chips we can already insert into our systems. How far is the human physical form going to be a data machine chucking out data read by sensors all over throughout our bodies in future, do you think?
I think that if that data is used for is owned by us and it's used for our benefit, it's a wonderful thing. Look what happens today. We just wait until that very same data presents itself in a very obvious way, and then at that stage we just get really scared and we act on it. That data is already there and everybody sees it. When I have a catch, if I have a cold, imagine if I could see that data days before I am infecting other people. That data, once I do have a cold and my nose starts running and I start sneezing, everybody else sees it, and it becomes apparent. And at that stage, I isolate myself and I try to get better. Imagine if I could see it days earlier. Imagine if you could do so with dementia, with cancer, with so many other diseases, that if we saw it early, we could fix them. There is no cancer that if we don't catch it very, very early, we wouldn't fix it. I have two very good friends now. One unfortunately caught their cancer very late, and exactly the same cancer caught very early by another. And the outcome are unfortunately very different for both. This is a good thing, and we should not dramatize it. We should actually cherish it. 70% of our expenditure in healthcare can be prevented or in predictable, preventable diseases. So I think the scenario you painted, it's a very good thing, and I can't wait for it to happen. The more data we can get, the sooner we see the problems, the sooner we see them, the sooner we can fix them. What the governments need to do is, on one hand, to make sure that that reality becomes common for us as fast as possible, but on the other hand, regulate it so that the same disaster that happened with our other data, where some social media managed to collect it, manipulate it, and create a lot of social ill with it, doesn't happen with our health data.
And Noor, what does that mean? That means sensors at a cellular level. Do you think we're going to become data machines, spewing out data with sensors at every kind of, even tiny cellular level?
I think we've seen this coming into reality. Actually, we've seen the Neuralink, for instance, led by Elon Musk, where you have kind of these small chips plugged into your brain and measures everything that's happening in your brain, all the activities, and then trying to kind of predict what's going to happen next, or what you're thinking about, or why you're feeling certain ways. So this is definitely happening on so many levels, I think. I think the kind of the reality that we will come to is that we can augment our abilities with these sensors. We get to understand ourselves better using those sensors, and we could, as Ali mentioned, we get to prevent ourselves from becoming ill by using those sensors. And those can really be anything from measuring our brain activities to measuring our heart rate, our blood pressure, to actually also be able to say whether there is a stroke, for instance. We can also predict that with those measures, and it can be probably a chip in your hand or in your brain that can measure everything from cellular activities to bigger measures around heart rate and blood pressure and so on and so forth. So it will come down to everything, but it will be more of augmentation than actually a threat, I would say, for us.
Well, brilliant. We're going to leave it there. I think what our three panelists have described there is really an extraordinary new world. We are at the cusp of a transition where technology can take us from a world where we are reactive, where we're passive, where we wait for things to go wrong. In a dark age, we are mystified. Largely, we have very little information until things happen, and then we act upon it, and then we deploy our brilliant doctors and nurses to help us recover. Transforming from that to a world where we have real-time data that can, because of algorithmic models, because of artificial intelligence, begin to predict when things might be going wrong. And so we go from a retroactive healthcare where we respond to things to a predictive and analytic healthcare where we can look forward to where things might go wrong and step in before they do, with our bodies as data producers, data machines, monitoring and logging at a cellular level in real time. It's a mind-boggling concept. It's also terrifying from a question of data privacy. How can we respond and secure that future, secure our data, our most private, intimate data? How can we make it all happen? It's tremendously exciting. We've had some basic and brilliant beginning insights with our panel. Now there's so much to go on to, which we could go on to. We don't have time, but I really want to thank the three of them so much. Ali Parsa, from Babylon Health, you know, Junaid Bajwa from Microsoft, and Noor Shaka from, I won't say beautiful AI, it's not, is it? It's gorgeous AI.
It's a glamorous.
Is that right?
It's a glamorous AI.
Glamorous AI.
It's a glamorous.
No, I'm so sorry. Glamorous AI. Perfect. Thank you, the three of you, so much.